Welcome, everybody. We're so glad you're here. My name is Mary Maeda of Canine Cancer Alliance. Canine Cancer Alliance is a nonprofit foundation focused on research and education about canine cancer and treatments. Our mission is to end dog cancer as we know it today so we can have safe and effective treatments that could become widely available for dogs. And our work is made possible by donations from individuals and families. Today, we're going to hear from Dr. Jeff Bryan about Elias Cancer Immunotherapy. Immunotherapy uses the patient's own immune system to fight cancer cells and has revolutionized human oncology, leading to cures for patients with very aggressive cancer, including metastatic cancer. There are now thousands of clinical trials with human cancer patients advancing immunotherapy. And what research is revealing is that immunotherapy treatment as monotherapy, as single agent treatment, is just not enough. When you combine 2, 3, or more immune modulating agents and approaches, that's when you start to see big gains and high response rates. And in last month's webinar, Dr. Bryan shared how his new clinical trial is investigating combining autologous vaccine with a new immune checkpoint inhibitor, CD200 ICI. Previously, Professor Mark Mamula has described his team's work with Dr. Chelsea Tripp, combining EGFR HER2 vaccine with PD-1 immune checkpoint inhibitor. So Elias Immunotherapy was designed up front as a multi-step immunotherapy and showed quite impressive pilot trial data. And since then, they've enrolled many more canine patients. And finally, earlier this year, March of 2025, Elias Cancer Immunotherapy became fully approved by USDA. By the way, it's not the FDA, but US Department of Agriculture that's responsible for regulatory approval of most immunotherapy treatments for dogs. That means that in the US, canine patients can receive this treatment without being part of a clinical trial. And maybe, possibly, it could be ordered as a treatment for other types of cancer. How effective is ECI? How safe is it? So here's Professor Jeff Bryan from University of Missouri. Welcome, Jeff.
Thank you for the opportunity to talk about Elias Immunotherapy. And I'm going to talk about it in two parts today. I want to first talk about the immune environment of the tumor to begin with, because it's very relevant and important to all immunotherapy that is going to be applied, and then discuss what we have learned about applying Elias Immunotherapy, starting with the pilot study and then working our way into some of the current data that we have. And first, I will say, in revealing conflict of interest, I am a member of the Scientific Advisory Board of Elias Animal Health, and so I do periodically receive travel reimbursement and honoraria for meetings with them, but I am not a shareholder in Elias, nor am I directly an employee of them. I did not join the Scientific Advisory Board until after the pilot study, when I saw what happened in that, and it was just such an amazing response in these dogs that I really wanted to have a role in helping to direct how the company develops this therapy further. I think everyone on the call is very aware that immunotherapy is the big thing, and we see these popular ads all the time. And these ads suggest that immunotherapy is the strongest way to stop cancer. We've certainly seen that there is a lot of efficacy in these genetically engineered immunotherapies, but there also is a lot of toxicity, and that's part of what is shown in immunotherapy ads a lot, is that if you take chemotherapy, you're going to have all of the classic toxicoses that we're used to thinking with chemo, losing your hair and feeling sick, whereas your life will stay the same with immunotherapy. And unfortunately, that's not always true, although this particular activated cell therapy has been shown to be quite tolerable for osteosarcoma. But we do believe that most of the spontaneous and durable cures of cancer often come from activating the immune system against that tumor. And so I want to talk about this in two acts today. And the first act is to talk about the challenge of what we're dealing with in terms of the tumor microenvironment and what our targets are there. most of us, when we think of cancer, think of a tumor as just a lump of all cancerous cells, of all bad malignant actors that are trying to potentially spread and threaten the life of the patient. And the first challenge that we face is that although it is true there are lots and lots of malignant cells, trillions by the time that we have detected this tumor, those cells are not all the same. And in fact, the cells have already started to undergo subclonal evolutions. And so there are cells with different targets on the surface, cells with different susceptibilities. And this is why chemotherapy does not often kill all the cells in a tumor, because there are often a subpopulation of cells that are pre-resistant before you've even started therapy. So we have a challenging target to begin with. And in addition to these cancer cells, though, there is a host of microenvironmental cells, many of them immune cells, and we're going to talk about those. The first cell to highlight are the CD8 positive T lymphocytes that are cytotoxic. These are the cells that we really want to be in and around the tumor, the ones that we're hoping will recognize mutant antigens on the surface of the tumor and actually kill those tumor cells. So when you read articles about tumor infiltrating lymphocyte therapies like TIL therapies, these are the cells that are of greatest interest in that, because these are cells that are already educated to attack mutant proteins associated with the tumor and kill the cells that hold those proteins. But because of the immune shield that the tumor has built around it, when those cells infiltrate the tumor, they either become quiescent or exhausted and will just sit there not doing what we're hoping they will do. And so TIL therapy approaches harvest these cells from patients' tumors and expand them and then reinfuse them in an activated state, hoping that they will now stay active and eliminate whatever tumor cells might be hiding after the surgical removal. Along with these are CD4 positive T helper cells. These are directors of the immune system that help to push it towards removing threats to the total organism. So invading pathogens, invading parasites, or the rise of cancer cells, a lot of that will be orchestrated by these CD4 positive helper cells. There also are these CD17 positive helper cells that are in there, the T helper 17 cells. These are cells that may help to direct an anti-tumor response, but conditionally can also protect the tumor from immune attack in some cases. And then these T regulatory cells are present, and their job is to suppress immune responses that are too robust against pathogens or other things, but they are also bent to the will of the tumor and are used to form a protective shield around the tumor to stop the immune system from destroying those tumor cells. There also can be B lymphocytes that are lymphocytes in the immune system that are responsible for making antibodies. And these have some potential role against cancer. And there's some evidence that some of the vaccines that have shown efficacy that cause antibody responses can potentially improve outcomes. But they are not really what we believe are the biggest actors against the tumor, which are the CD8 positive cytotoxic T cells, and they make those antibodies. And antibodies can be a double-edged sword. Sometimes those antibodies bind to the tumor cell and they trigger immune responses that lead to the destruction of that tumor cell. Sometimes those antibodies bind in the microenvironment and actually serve to block antigens that could potentially be targets for cell destruction, or actually serve as a suppressive antibodies in the microenvironment. Natural killer cells are discussed a lot and are being evaluated as potential therapies for killing tumor cells. They are the cells that are not specific to particular mutated proteins, but are looking for cells that have particular characteristics, like cells that are not displaying their typical "this is who I am" molecules on their surface, and they will eliminate some of those cells. And if you activate enough natural killer cells, you can potentially cause sufficient anti-tumor immunity to cure patients in some cases, but they also can be suppressed by the same immune shield that the tumor builds around itself to stop the more specific anti-tumor responses of the cytotoxic killer T cells. There are also macrophages that hang around in these tumors. And macrophages mean in Latin literally big eater. These are the cells that are there to engulf pathogens, engulf cells that shouldn't be there and eat them. They're also there to clean up dead cells and other debris in the body. And they can come in two forms. There are the M1 polarized macrophages, which are typically more pro-inflammatory, more anti-tumor. But then there are also M2 macrophages, which are more typically anti-inflammatory and can contribute to that protective immune shield around the tumor. And then there are these myeloid-derived suppressor cells that come in from the bone marrow, as their name implies, being myeloid-derived. They come from the bone marrow. And these secrete a lot of suppressive compounds in the area, a lot of signals, cytokines, basically immune hormones that tell all of the immune cells in the area to calm down and that there is not a big threat in the area. Again, contributing really substantially to that immune shield that is present around the tumor to stop immune destruction of that tumor. And then finally, there are a lot of stromal cells in the environment, and these are fibrous cells or other supporting type cells that can not only provide support to the tumor cells and even nutrients to the tumor cells, but also help grow new blood vessels for the tumor to help the tumor grow, and can often even remodel the structural environment to allow the tumor cells to invade further and even enter the vasculature and spread to distant sites to form metastatic lesions. And so what really comes out of this picture as you look at it is that a tumor, when it sits there in its physical form, is a very complex, biodiverse microenvironment that has many immune actors in that region. And this is why immunotherapies are of such great interest to trying to manage tumors, because we recognize that there are very specific anti-cancer cells present in this microenvironment. And if we can turn those on and we can turn off the regulatory cells, we can cause the immune system to eliminate these cancerous cells if we can recognize every last cancer cell and destroy it. So going forward, I want you to remember that this is a mix of good guys and bad guys. And the bad guys are the cancer cells themselves, and then the immune cells that it uses to build a shield around itself. And unfortunately, that even includes the unwitting stromal cells that are just regular, normal body cells that are present in the area, but are being trained by the cancer cells to help do the malignant bidding of the tumor itself. But there are the good guys in the area, the macrophages, the CD8 positive cytotoxic T cells, the T helper cells that help direct that anti-tumor immunity, and the natural killer cells that can potentially help to eliminate cancer cells that we do not recognize the specific mutations on their surface. And these are the players that we're trying to manipulate when we're using immunotherapies of any kind to cause an anti-tumor response. So with that shared understanding of how complex this tumor environment is, I want to talk about Elias Immunotherapy, which is a form of vaccine-enhanced adoptive cell therapy. And this is a schematic from the company that shows the process of this procedure. Initially, the tumor is removed, and in the case of osteosarcoma, currently, that involves amputation. And the reason that amputation is important is, one, we want to take away the pain that's associated with the cancer. Two, we want to be able to collect enough tumor cells to create vaccines so that we can retrain the immune system to recognize the whole panoply of mutations that are present on those tumor cells. And three, we want to remove that very well organized tumor immunosuppressive microenvironment that acts as a shield against the immune system and stops the immune system from killing the cancer cells. So those cells are harvested physically from the tumor, and I'll show you a picture, but they're put into a vial of cell culture medium to keep them alive and happy, going to the lab in Kansas, where the Elias workers then turn these into vaccines of the actual tumor cells themselves, expressing their mutant proteins on the surface in the appropriate context of the immune stimuli that are necessary to cause the generation of anti-cancer lymphocytes. So the vaccine series are administered intradermally in the skin. So they are administered away from this immune suppressive microenvironment of the tumor and are given in an area that is very rich in immune cells, and that then causes the immune system to generate lymphocytes that are very specifically targeted to the cancer mutations. After a few weeks of vaccination, we can then harvest those immune cells from the blood in a process called apheresis. This uses a machine that's very much like a machine that you might go donate plasma with or donate platelets with. And then that product of cells that are product of peripheral blood mononuclear cells that contains a lot of these lymphocytes is sent to the Elias laboratory. And again, in the laboratory, those cells are activated and expanded outside the body that really increases greatly the number of lymphocytes and makes them very angry. So they want to attack their target as soon as they see their target again. A week later, those are returned to the hospital and infused into the patient through a blood transfusion, essentially. And then we follow that up with a low dose of an immune hormone called interleukin 2 to keep those cells alive and angry against the tumor over a period of a few weeks afterwards. So there are 5 injections given every other day, starting the day after the T cell infusion, about 7 days worth of injections, and then we allow them to go on and just have follow-up monitoring after that. In the initial pilot study, dogs were enrolled if they had limb radiographs and cytology of the mass that was consistent with osteosarcoma and then later confirmed on biopsy. They had thoracic radiographs showing that they were not metastatic to their lungs in a macroscopic fashion. We could not see any evidence of tumors in their lungs at the time. And they had blood work that was consistent with a healthy dog prepared to receive immunotherapy. And in that study, we also performed a bone scan that was looking for evidence of metastatic disease to bone. And so this is what a bone scan would look like. This is an osteosarcoma patient, not one from our study or even tried to enroll in the study, that you can see has metastatic lesions in its ribs. This dog had multiple metastases, but this is very sensitive for finding second lesions elsewhere in the skeleton, which is important if you're going to amputate a limb. It would be sad to have a dog developing a new tumor in another limb that might require a second amputation, because many dogs will not perform well as 2-legged dogs, whereas they perform great as 3-legged dogs. And there was only one dog that was eliminated from the study based on the bone scan in this case. So these dogs were not pre-selected in any way that was different from how we typically like to screen osteosarcoma patients here at MU. So this is what the cell culture medium looks like. The tumor is harvested with surgical instruments after the amputation is complete and put into this medium. It's sent off to the lab, and then the vaccines come back frozen like this. And then we draw them up and we can administer them intradermally to the patient. And then after they have received 3 vaccines and let another week pass, we perform apheresis. This is what the apheresis machine looks like, the Spectra Optia. And then that results in a bag that would be hanging right here of their immune cells that are sent out and cultured in plate systems at Elias. And then they come back and are given this killer T cell infusion as a blood transfusion. So in the first 14 dogs that we treated in this clinical trial, we paid close attention to any of the toxicoses that they might have from this immunotherapy treatment. And by and large, they were very low grade, basically grade 1 and grade 2. During the apheresis, one dog had a grade 2 atrioventricular block that we think was due to the calcium binding anticoagulant associated with the apheresis. Did not cause the dog any blood pressure problems or anything else that made us have to stop the procedure or the anesthesia, and it resolved immediately as soon as the apheresis was completed. And we also had some grade 2 neutropenia following the apheresis, where a dog had persistent low neutrophil counts in the blood, lasted about a week and a half, and then resolved completely on its own as well. One dog had a pretty significant reaction to the T cell infusion, and this was the very first dog that we gave the T cell infusion to, and we gave no pre-medicants whatsoever. Since this time, we do give some anti-nausea medications as well as an anti-inflammatory on the morning of the infusion, and since that time, we've had no significant febrile responses or major GI responses that we've seen. Some of the interleukin-2 patients or dogs that after they got the interleukin-2, we attributed some of the diarrhea to that, but these dogs also had received their T-cell infusion and were housed in the hospital overnight at the time. Since we started releasing the dogs from the hospital after the T-cell infusion, we have seen a lot less stress colitis and things and very little GI effect at all. And then there were some unrelated things that happened around the time of these surgeries and immunotherapies that we did not believe were related to the immune treatment. And these were the outcomes that we saw in this first group of 14 dogs. The disease-free interval was 213 days, which is not extremely long for osteosarcoma. However, there were some interesting outcomes here. Many of the dogs that developed metastatic disease went on to live a substantial amount of time with their metastatic disease, more than we are typically used to in dogs that have been treated with chemotherapy after amputation. And we had one dog that had a cytologically confirmed osteosarcoma metastasis to its skin that underwent spontaneous remission of that metastasis. It was not removed surgically, it just suddenly resolved. And that dog ended up being a long-term responder and lived 5 years after amputation before being euthanized for reasons unrelated to the osteosarcoma, never relapsed in a life-threatening way, only had that skin lesion. But the really remarkable thing was that the average survival of these dogs was over a year with no chemotherapy whatsoever. They received amputation and then they received immunotherapy, did not get any chemotherapy. And in fact, 5 of the 14 dogs lived over 2 years, and 3 of those dogs never died of osteosarcoma. When they finally were euthanized, all of them were disease-free at the time, and so essentially were cured of their osteosarcoma by this approach, which is a really remarkable outcome given a relatively small number of dogs. And the other thing happening in history at this time is that these dogs were enrolled at a time that we had multiple osteosarcoma studies happening, including nationwide comparative oncology trials studies that were enrolling as well. And so these dogs were contemporaneously enrolled with a number of other dogs and had remarkably good outcomes. To contextualize this 415-day median survival of these 5 dogs, I want to include this survival curve from an early study from Dr. McEwen's lab years ago from Wisconsin that looked at this other immunotherapy, immuramyl tripeptide, and the dogs that were amputated and got that immunotherapy had an improved survival compared to dogs that were amputated alone. And these dogs that only received amputation lived on average only 77 days. There's a larger study than this that was published by Dr. Spodnik, a retrospective study that showed about a 4-month survival, 128 days with amputation alone. But long-term survivals are almost never seen in dogs that are only amputated. And so this outcome really gives very strong indication of a substantial response to the immunotherapy. In a clinical cancer research article that we wrote, my colleague and I, that reviews immunotherapy in dogs, we did publish some of the Elias data of the commercial dogs. And again, this would be the 128-day Spodnik amputation average survival if the amputation alone is what they underwent. And you can see the median is a lot higher, over about 250 days in this case, with some significant long-term survivors in this group of dogs, again, not treated with chemotherapy. But all along, we have been asked and we have wondered what the impact of combining chemotherapy with this might be. And so this last section I want to share with you was just presented at ACVIM, and I'm just going to show you the slides that we presented from ACVIM, so you'll see that there is immediately a different format. And this was a prospectively identified cohort of dogs that Elias was aware of receiving chemotherapy followed by the Elias immunotherapy. And they eventually or were hoping to enroll 30 dogs, and we will continue to add dogs to this. But this is a presentation of 22 dogs at this point. And so there were multiple clinics that enrolled in this case. These dogs had newly diagnosed appendicular osteosarcoma without visible metastasis on staging studies, that they were they were amputated for cancer cell collection for the ECI, and they were compared to a group of dogs from the Comparative Oncology Trials Consortium study that was happening at the same time as that original pilot study that was done. And so in this case, you can see the flow sheet here that the tumor was removed through amputation and submitted for the cancer tissue was submitted for vaccine preparation. They received chemotherapy, and I'll show you that was a range of administration types. And then they started their vaccine series following the chemotherapy sometime between week 4 and 7, then underwent their apheresis, activated T-cell infusion, and then their IL-2 injection. And so these are what the dogs were that were enrolled in this. There were 22 dogs total. They had very typical locations of their tumors on average, with also a distribution of breeds that is very typical of this. Average about 35 kilograms or close to 80 pounds. So these are big dogs, and a pretty equal mix of males and females, and about an average age of about 7 years, which is about typical for osteosarcoma for the dogs as well. We receive the data that is published in the data commons from the COTC 022 study and selected 22 matching dogs that were matched on tumor location, breed, gender, and also the size of the dog. And each of the dogs that were selected as match controls had to receive at least 2 chemotherapy doses in amputation, followed by 4 doses of the planned carboplatin chemotherapy, so that their survival was similar to the group of dogs at a minimum that were receiving this chemotherapy plus the Elias immunotherapy, matching the timeline as closely as possible. Within this group of dogs that received chemo and the immunotherapy, 20 dogs received carboplatin first. 2 of them received, or sorry, 4 of them, no, 2 of them, sorry, I'm doing math in my head quickly. 2 of them received doxorubicin because of a carboplatin inavailability at the time. There was a shortage nationally of carboplatin, and some dogs were not able to get the drug because it couldn't be purchased. 18 dogs in the combination group received only 1 or 2 chemotherapy doses, and 21 of the 22 dogs completed all the way through the T-cell infusion because they were not identified to have metastatic disease. 1 dog exited the evaluation because of the development of metastatic disease. The number of doses total, 14 dogs received a single dose, 4 dogs received 2 doses, 3 dogs received 3 doses, and 1 dog out of these 22 received 4 doses. In the matched control set, 4 dogs received only 2 doses of carboplatin before failing to metastatic disease. 2 of them received 3 doses before failing to metastatic disease, and 16 of the 22 in the control group completed all 4 planned doses of carboplatin. And these are the outcomes that are really quite striking in this case in terms of the significance, both in clinical significance as well as statistical significance. The survival curves clearly diverge substantially. This is the group of dogs that received amputation and then chemotherapy for their treatment and are published in the COTC data set. These are the matched controls. These are the dogs that received chemotherapy plus the Elias immunotherapy. And you can see that their survival was substantially longer, 494 days versus 207 average day survival in the dogs that were planned to get only amputation and chemotherapy. And what's really remarkable is that at this time of this analysis, the 1-year survival rate was over 60% for the dogs that got chemotherapy plus immunotherapy. And that's a really unusually positive outcome. And this is something that we are really hoping is going to not be any kind of anomaly in this group set, but rather be what is likely to happen when we combine chemotherapy plus immunotherapy. And we are going to present a subset of this group that are included in this that received just the single dose of carboplatin followed by Elias Immunotherapy at the Veterinary Cancer Society this September in Salt Lake City. And those dogs have performed even better than this on average. So it appears that a single dose of carboplatin followed by the immunotherapy may be sufficient to get a better outcome than immunotherapy alone or chemotherapy alone.
Jeff, so in that
Yes,
slide, if you could go back, about 25% of the dogs became long-term survivors, almost
correct.
effectively cured.
Yeah. I think about
So,
total about 30 because we have some of these censored dogs have gone on to live longer, so that tail has come up a little bit.
okay. And then I guess there's a news release saying that 71% had 12-month survival rate of
That's
71%.
correct.
Is
And
that number still correct?
that's the updated evaluation because of the dogs that are still alive and that we continue to follow.
Okay, awesome. That's really amazing. And is it because the chemotherapy is inducing immunogenic cell death and actually stimulating immune system, or is it because it's decreasing the tumor burden? Why do you think chemo works
Yeah.
so well here?
I mean, I think that it is not clear yet exactly why that's happening. What I will say is that there is evidence in past immunotherapy studies, particularly if you look at the neuramyl tripeptide data that came out of Dr. McEwen's laboratory in Wisconsin, that dogs that were treated first with chemotherapy and then with immunotherapy had better outcomes than dogs that receive the immunotherapy alone or even receive them in immediate combination. And so this fits that long-term pattern that's been seen in the literature in several instances of really well-controlled studies in the past. And so I think this is something that is real. It's a real phenomenon, but the exact mechanism has never been fully determined. And so you could hypothesize that there could be an improved cell kill when they receive chemotherapy immediately after surgery. And so you're functionally reducing the metastatic burden that the immunotherapy needs to eliminate. You could also be inducing immunogenic cell death, which could also cause a better generation of lymphocytes against those metastatic cells that are hiding in the body. And so, therefore, when you vaccinate them and then collect the immune outcome from a combination of the vaccine plus the immunogenic cell death from the chemotherapy, you might get a better activated T cell product than you're getting if you only do the vaccine. But I also wonder if there is not some kind of an immune resetting, that there might be an impact of the carboplatin on the immunosuppressive arm of the immune system. So you may have a reduction in T regulatory cells. It may cause alterations in myeloid-derived suppressor cells, something that makes a difference in the way the immune system can respond to the vaccine priming, in this case, at the intradermal location. And so I think there are a number of possibilities, and Dr. McEwen's laboratory was not able to elucidate exactly why the reason that the cisplatin followed by the neuramyl tripeptide was better than giving them in combination or giving either one alone. But these data fit very well with that tradition that was generated out of that laboratory.
So now, how about the dogs who did get 4 doses of chemo with
Yeah,
Elias?
they also were part of this good outcome. But if you look at just the subsets that did the best, it really seems to be that single dose of carboplatin plus the immunotherapy. And there's some benefit to that financially for the families as well, that if that single dose of chemotherapy is beneficial, it is less cumbersome, fewer visits, less risk of febrile neutropenia, and less expense than trying to get in a full dose of the carboplatin chemotherapy first. And there have been some uncontrolled studies in the past that looked at giving immunotherapy following completion of chemotherapy. And those are harder to interpret because when you start to look at dogs that have survived to the end of chemotherapy without developing metastatic disease, you may be subselecting for a group of better performers that had later metastasis or less aggressive metastasis. And so how that outcome is interpreted in comparison to other chemo alone studies or immuno alone studies is really challenging. The thing I really like about this data set, and particularly the single carboplatin data set, is that the timing relative to the original diagnosis of osteosarcoma is much more similar to the chemotherapy papers as well as the immunotherapy only papers. And that really makes this outcome stand apart substantially from those other outcomes. And as I said, hopefully this will hold and we'll see that this combination will really make this activated cell therapy much more effective for these dogs. And a 70% chance of survival at 1 year is a really different prospect for osteosarcoma dogs, and I think a hugely better outcome. And with the immunotherapy now having been approved by the USDA and therefore insurance companies starting to cover it more routinely, I think that this becomes more within reach of a lot of families.
I'll let you finish with your summary and we have more
Yeah, and
questions.
so just for the summary of the take-home points here, the vaccine-enhanced adoptive cell therapy is effective as an adjuvant to amputation for osteosarcoma, and it is now a USDA-approved therapy for treating osteosarcoma with amputation. I would emphasize to the families and the veterinarians on the call and who see this in the future that referral for this therapy has to occur before amputation. If the tumor is gone, we don't have that vaccine material, and therefore a vaccine can't be created to prime the immune system to really make all of these lymphocytes that are important to treating the metastatic disease that's hiding. And that a combination of chemotherapy and possibly a single dose of chemotherapy plus this immunotherapy may be more effective than either one alone. And also that Elias Immunotherapy is available in most regions of the country. I frequently get emails with families whose dogs have developed osteosarcoma asking if they could travel to Columbia, Missouri, could they come and get treatment? And I can almost always refer them through Elias to somebody closer to them so that their pet can be treated at home in a more comfortable environment than having to travel a long way.
That's amazing. Thank you, Jeff. Thank you so much. This
Sure
is really
thing.
good to hear. So do you think Miramil tripeptide clinical trial, if they had only given dogs one dose after surgery of chemo?
Good question. Hard to say. It's frustrating that is not available here in the US readily because that really did show promise and, in fact, is used in other countries around the world for treating kids with osteosarcoma on the human side. And so it's a product that I do wish we had because I think that it has clear efficacy. And so it would be neat to repeat some of those old studies and do now that we have the capability of doing much more elegant immunomonitoring, collect the samples necessary to really tease out that interaction. And I think that it would be neat in the future to apply for some larger federal grants with Elias to start teasing out some of the immune underlying mechanisms between this interaction between the carboplatin and chemotherapy, even the doxorubicin dogs, and the Elias immunotherapy in this case, because I think that is an important it's important to understand that in the long haul because I think that may contain an important key to helping understand how we could also benefit people in the metastatic setting for this. I think I saw an interesting question that I would like to address just pop up about if the tumor's removed, but biopsy samples are still available, is it a possibility? And the answer to that is no, because the cells have to be alive. So unfortunately, we cannot develop a whole cell or live cell vaccine from that. There are techniques to develop peptide vaccines from biopsy preserved tissue, but the peptide vaccination priming followed by this activated cell therapy has not been tested by Elias or anyone else yet. And so we don't know that it's the same as what we're doing with this Elias immunotherapy.
Now, how about synergies with EGFR HER2 vaccine?
A great question. I think that any way that you can develop more potentially tumor reactive lymphocyte clones, the more likely that you're going to have a positive outcome from your activated cell therapy. I see a question about Gilvetmab, and we have a study that is open to enroll for families who are choosing the Elias vaccine that we could use gilvetmab in combination for PD-1 inhibition. And theoretically, that could again result in a more effective antigen presentation and more active T cell clones coming out the other side of the vaccination and then the apheresis. But that has yet to be tested. We have not enrolled any dogs in that yet and hope to start enrolling dogs in that soon because I think that's a very important question for sure.
And IL-2 is given
Mhm.
after everything
Yeah.
now, right? Now, how about giving that earlier? Or perhaps if the dog progresses and ends up with metastasis, IL-2 aerosolized therapy,
Yeah.
could that help?
There, Chan Kana years ago showed the benefit of IL-2 aerosolized therapy using a liposomal encapsulated IL-2 at the time. It is possible, and I have heard anecdotally that the aqueous IL-2 is a little more toxic inhaled. It causes more of a just a localized immune reaction, like a bad flu or something. And I think there was some benefit to that liposomal encapsulation. UC Davis has been looking at IL-15 inhaled, and so I do think that there is a lot of opportunity to use these immune signals in addition to or after to reawaken these anti-tumor immunity or immune responses because given that you're giving these immune cells back, it's likely that you are leaving behind memory cells in these dogs that recognize the clones of cancer that they want to kill. And so, if you can once again break that immune shield on a metastatic lesion and upregulate that immune response, you could potentially break tolerance and result in an anti-tumor response in that case, yes.
I see. Now, can you say something about the cost and insurance coverage?
Yeah, I mean the cost is substantial because it is a bespoke process. We're making every part of it custom for that individual dog. A lot like certainly nowhere near on the order of magnitude of the CAR T studies on the human side, where the approved CAR T cells cost the better part of $750,000 per treatment because of the genetic engineering and the individual preparation for each one. In our practice, the cost of the Elias immunotherapy is somewhere around $20,000 or a little bit more, including the amputation. And the addition of the carboplatin treatment does not add much to that, which is nice because that keeps it still within that. And we have had now more than one insurance company cover the Elias immunotherapy process. And so hopefully we'll see that become widespread now that it has the USDA approval.
I see. Now, there are studies showing that if there's greater tumor mutational burden, more mutations, then autologous vaccine works better. Do you think that if you do comprehensive genomic profiling, you could identify dogs who might respond better to Elias immunotherapy?
That is an important question. All of the data that have been published so far looking at the genomic sequencing of osteosarcomas in dogs, I don't think any of that can be characterized as low mutational burden. And so, how you would really compare the mutational. I don't know how you find the cutoff in osteosarcoma. I mean, these tumors are severely genomically deranged. And that's been true of the work that Shirley Chu here out of the University of Missouri published looking at primary and metastatic tumor pairs. Heather Gardner publishing a lot of a larger data set out of Tufts University, stuff that has come out of the Broad. I mean, none of it shows minimal mutation in any osteosarcoma cases. And so I think that is probably not a substantial variable and maybe not worth pursuing as an evaluation in osteosarcoma per se. What I do think is worth looking at in osteosarcoma is what are the patterns of most stereotypical mutation that might have druggable targets in them, and you could combine specific targeted therapies in addition to the immunotherapy as well, particularly in the metastatic setting, because I think that there are a few candidates there that are quite interesting, including things in the EGFR HER2 lineage, and given the evidence that vaccinating against the epidermal growth factor receptor does seem to improve outcome in dogs, suggests that there might be more opportunity to drug that pathway and have some benefit.
I see. So you did have in the trial some dogs who had metastasis, but in general, if the dog already has metastasis, does trying
So
Elias
good
immunotherapy?
question. In the trial, none of the dogs had metastasis at the start. They developed metastasis in the course of the trial, and we had several dogs live with very substantial survivals with really no clinical signs of their metastasis longer than what we typically see, suggesting to me that there might have been a loose equilibrium between the immune system and the metastatic lesions for a time at least before the metastatic lesions eventually progressed and had a huge impact on the dog's quality of life. I have treated some dogs that had metastasis at the start, and the clients wanted to continue anyway during the commercial phase that was allowed before the final approval. It has not been my impression that as a single therapy that has been nearly as successful as we would have hoped, but that is something that our Gilvetmab study allows for metastasis at the time of enrollment if the clients want to pursue that. And we're hoping that potentially adding checkpoint inhibition to the activated T cell therapy will wind up with a better outcome than the activated T cell therapy alone. That's an open question. And PD-1 inhibition and CTLA-4 inhibition have not been major game changers in metastatic osteosarcoma on the human side so far. Whether that will hold true for dogs or not is not clear yet. I certainly think it's worth trying, but even if it had a substantial impact, making a better outcome for 30% of the dogs would still be a big impact. And so it may take some time to generate enough patients to really be able to find that difference. We'll have to see how that progresses.
Last month, we had Bryan give a talk about the combination clinical trial, Ardent sponsored immunotherapy. And so they're using CD200 immune checkpoint inhibitor. And I was curious what you thought about combining Elias immunotherapy with CD200.
I think it's very interesting, and I'm actually doing research in the CD200 area as well. I have a student right now who's working with some both histochemistry on tumors, looking at the distribution of CD200, and we're also going to do some spatial transcriptomics to understand exactly which cells are expressing it in the context of osteosarcoma specifically, and understand what kind of a target that might be for osteosarcoma. The data that have come out of Minnesota looking in brain tumors suggest that CD200 is active in that immune axis with brain tumors as well and enhances the antigen presentation associated with the autologous vaccine. So I do think that CD200 is quite interesting in the osteosarcoma space and probably very interesting in the Elias osteosarcoma space as well.
Awesome. Now, last year, Professor Mark Mamula from Yale, he shared the result with dogs who are given palliative radiation, dogs who are not candidates for surgery, given
Yeah.
palliative radiation plus EGFR HER2 vaccine, and the median survival was almost a year. And so the hypothesis is perhaps low dose palliative radiation is inducing tumor antigen release. So I was curious what you thought about other ways of priming T cells if a dog is not candidate for surgery.
I think the radiation is quite interesting, and there are a number of strategies that could be of great interest to that. Both the external beam radiation, but also with radiopharmaceuticals. And we have a study that we are participating in with Johns Hopkins University using an antibody targeted alpha emitting and radionuclide against the osteosarcoma cells. And the alphas have some very interesting properties, highly lethal to the cells that they interact with, and could potentially cause very substantially immunogenic cell death. The other thing that's been looked at, and Wisconsin has published a study looking at using radiopharmaceuticals targeted to the tumor microenvironment to eliminate tumor suppressive cells, or excuse me, immune suppressive cells in the tumor microenvironment, sort of resetting that immune shield and therefore allowing the tumor microenvironment to be more immunogenic as well. And so that's another interesting strategy. And so I am a very strong believer that combining radiation therapy is a very important piece of this. We've struggled a little bit with the Elias procedure and combining radiotherapy because if we irradiate the tumor before removal, will the cells expand substantially, or will we get enough cells to create the vaccine that we want? And that's a risk that could eliminate the Elias as a possibility if you are too effective at killing the cells with the radiation. But treating the tumors before amputation, when you're really leaving behind only microscopic disease, could potentially improve our ability to have an immune response against those tumors after the amputation. And so I think that all of that is an important open question, and it makes sense to me that combining radiotherapy with the EGFR vaccine is a reasonable thing to do, and we'll have to see what other immunotherapies might benefit from that interaction.
Therapy and also irreversible electroporation or even electrochemo. I've heard that they might be able to induce immunogenic cell death. Could that replace the first step of surgery and autologous vaccination?
Yeah, that's an interesting question too. I mean, sort of an in situ vaccination, if you will. And certainly Dr. Tui at Virginia Tech is looking at histotripsy to destroy the cells as well. So a lot of ablative therapeutics are calibrated to potentially cause that in situ vaccination, if you will. I think the question will simply be, can we effectively destroy the primary tumor in a way that leaves a bone sufficiently intact that you don't need to amputate them because it fractures or something like that, because that would be a nice advantage to be able to leave the bone behind if you could and keep the limb. So always limb sparing is of interest in osteosarcoma. We have a study going here at MU doing limb sparing surgery and then harvesting the tumor tissue for the vaccination. And that's another surgical limb sparing way of trying to keep the limb intact. I think all of that is possible. The challenge that I see and that I like about this approach that Elias has chosen is that we are really trying to induce that immune response in a tissue that is away from the context of the immunosuppressive microenvironment of the primary tumor. And so that becomes the question. If you destroy the tumor in situ in a very immunogenic way, but you do it in the presence of already the immune shield that's sitting around the tumor, are you as effective as you hope to be? And I don't know if we yet know the answer to that question. And so whether it's histotripsy or H-fire or electrochemotherapy or cryotherapy, I'm not sure that we yet know which one is the most immunogenic way to kill the tumor and therefore the most effective. And it could be in the end, the one that wins the race is the one that more effectively kills the immune constituents that are protective of the tumor than the others. And so we'll have to see which one that is.
Okay. How about losartan, tacrolimus, propranolol, adding that to suppress MDSCs and changing the tumor microenvironment in conjunction with Elias immunotherapy?
Yeah, that's an interesting question because so with palladiolosartan, there is definitely evidence that in the gross disease setting, it has an impact. We have not yet seen evidence that administering that immediately following chemotherapy as a maintenance therapy, if you will, has extended the disease-free interval and survival any better than if you just add it once metastatic disease sets in. Similarly, Palladia itself did not, and Palladia plus cyclophosphamide in a metronomic administration did not improve outcomes substantially for osteosarcoma or hemangiosarcoma used as an adjuvant continued maintenance therapy after chemotherapy. I don't know is the bottom line with that. I don't know if you have those things present, do you wind up delaying onset of metastatic disease and improving survival, or do you just result in selecting for clones of the tumors that are resistant to the effects of those drugs and the resulting immune response from those drugs? I don't know. We always like to think that when we intervene, we're going to do something good, but I don't know that we yet know that. And so our practice here at the University of Missouri is to reserve palladiolosartan for the development of metastatic disease. We've now tried it in a number of metastatic sarcomas, not just osteosarcoma. I would say with early mixed results, and we've seen what appear to be some benefit in some dogs, and we've seen other dogs progress as we would have expected without any therapy at all. And so is that just the 50-50 conundrum that we see with osteosarcoma that plays out in a small number of dogs, or is there some histology specific benefit to that drug combination? I don't know.
Okay. Okay. Now, a big question, other types of cancer. Can patients with other types of cancer receive Elias immunotherapy?
They can, yes. They, with this approval, you can submit tumors of really any kind. And I think that there is reason to think that this could work for tumors that have mutations that are interesting to the immune system of really any histology. How well it will work across the board in hemangiosarcoma or other things is not yet clear. We haven't tested that. But I think that there is reason to expect that there could be benefit for a number of types of tumors. And so for families that have the wherewithal to consider that, I don't think it's a crazy thing to do. We just don't have the data to say whether it's more or less or the same effective in other tumors.
Okay.
And I think
And
there are
big,
other tumors for which that question of the mutational burden might become a more substantial question.
oh, that's interesting. So, just to let the audience know, in human medicine, looking at mutational burden is something they do routinely, but it finally became available for canine patients just this year. There is a company called Vetomics that does a comprehensive genomic profiling. So, the older genomic profiling tools couldn't do that. So, Phytocure could not do that, but Vetomics test does actually measure. Yeah. So possibly for other types of cancer, maybe doing that test first to see if it's worth doing, Elias, would be
Yeah, it could be
maybe.
very interesting. And especially if you had a patient in a metastatic setting where it was an oligometastatic lesion where you had a single metastasis that could be removed surgically. So again, you're overall treating probably micrometastatic disease. I think that there is theoretical reason to believe that could be helpful.
That's great to know. Now, one thing that concerns me is that you have to know that you want to get Elias immunotherapy before you have surgery, right?
Yeah.
How do you make that happen? Because most of us, when my dog had osteosarcoma, he had x-rays and the doctor said it might be cancer. So he went and had surgery. And are more surgeons becoming aware or general practice doctors becoming aware?
I definitely think that the first step in addressing that is an awareness campaign that there are options to be considered for osteosarcoma that need live tumor. And so thinking of other diagnostics besides simply amputation to figure out what that lesion in the bone is are important. And I will point out that cytology of bone lesions has become really the mainstay of our diagnostics for tissue diagnosis for bone tumors in most oncology practices. We have found as a profession that the cytological samples that we can get out of fine needle aspirate of the bone are of equal quality and possibly greater diagnostic benefit and less risk even than taking core biopsies of those lesions. And so it is routine in our practice to aspirate these every single time. Our clinical pathology laboratory can perform alkaline phosphatase staining on the slides that we submit, which, if they are positive, greatly increase the likelihood that you're dealing with a primary bone tumor, which is most commonly osteosarcoma. And that allows us to get a pretty definitive diagnosis preoperatively. Excuse me. And so I recommend anybody whose dog develops a bone lesion to see someone, either a general practitioner or an oncologist, who can accomplish that cytological evaluation of the bone tumor before you go to surgery. We obviously don't want to delay surgery any longer than necessary because the dogs have a great deal of pain and it's obviously a life and death race against the clock with this stupid disease. And so we want to get that dealt with. But importantly, planning ahead is a critical thing to make sure that we are going to make the right decisions for these dogs. And that's where I think doing things like what you're doing and making people aware that this is a treatment option that has the potential even for cure in some cases. And that way, families that have dogs who are of breeds that are at risk can prepare themselves ahead of time so that if my dog ever develops a problem like this, I have the resources and the plan in place to be able to access this kind of therapy. I think that's really important.
We need educational campaign, and we probably need more people getting pet insurance.
Yeah. The insurance is going to be very important. And with the costs of supplies and personnel and veterinary care rising across the country, I think that using the insurance companies to help make sure that our beloved family members can get the care they need is going to be pretty critical.
So there's been really fascinating gut microbiome studies related to cancer immunotherapy, especially with human patients. And we're
Yes.
funding a couple of microbiome studies. But are most of these dogs exposed to antibiotics during Elias immunotherapy? Do you think?
No, they're not actually. I would say that probably the majority of them get a single dose of cefazolin at the time of surgery, as is routine for most major surgeries, just to reduce the chances of intraoperative infection. But one of the nice things is that febrile neutropenia is not really a feature of Elias immunotherapy, and periodic redosing with antimicrobials to cover febrile episodes is not a feature of this treatment. And that is, I think, a huge benefit to it. I don't know what the microbiome of the survivors and non-survivors looks like in this case. And I do think that is a truly fascinating question, and recognizing that in terms of sheer cell numbers, we are more bacteria than we are human, and dogs are more bacteria than they are canine is kind of a crazy reality. And realizing that disproportionate representation of those cells has an impact on health and well-being and response to therapies is really important. How we go about monitoring that and managing that in a practical sense, given the knowledge we have right now, which is pretty limited, it's really an overwhelming concern that I have about all of our clinical trials, because I don't think it's at all likely that immunotherapy is the only thing that is impacted by microbiome. I'm certain that the efficacies of chemotherapies in dogs are, I'm sure, microbiome impacted as well. The metabolism of a lot of the drugs is microbiome impacted, certainly, and we don't understand how to figure that out right now. And so it is, I prefer to just be ignorant of it at the moment because I don't know how to use the information. My colleague Lindsay Donnelly, who was here for quite a while at the University of Missouri, did some interesting work in that and really showed that there were some substantial differences during and after chemotherapy, and those might have had an association with outcome. But we need more people working on that question who have a real passion for that area.
So there are several commercially available fecal transplant pills,
Yeah,
and they're about $180 for a 30-day supply. So there's no study showing that it could help, but there are human studies that shows that just with
yeah.
fecal transplant oral pills from healthy individuals that it could boost the immunotherapy response rate. So that's a really fascinating thing that we're really interested in also.
It really is. Yeah, yeah.
Okay. In your view, do you think cancer rate is increasing for dogs?
Great question. I think that is a hard question to answer with a great deal of intellectual integrity, because the understanding of cancer over the course of my career, that I began vet school in 1989, and there were really only a small handful of oncologists in the world at the time in the veterinary space. I was somewhere around the 300th oncologist that was board certified by the ACVIM, and now we're way over double that. The cancer as a concept, the diagnostics around cancer, the willingness of the animal owning public to not only treat cancer, but demand new treatments for cancer and better treatments for cancer has amplified so exponentially since I began my career in veterinary medicine, that I think that it's really difficult to tease out the awareness and the ability to diagnose cancer from a real change in incidence of cancer. We know on the human side through really solid data that there are certain cancers that are increasing in incidence. And sort of most terrifyingly lately, colorectal carcinoma in young people, which is really scary because that used to be pretty exclusively a geriatric cancer problem. So why that's happening is not clear. I'm sure that there are subsets of cancer within our pet populations that are expanding, partly through genetics and breeds that are predisposed to particular cancers. Certainly, histiocytic sarcoma was nothing that I experienced a lot in my early career with any frequency. And it's something we treat daily now, which is, I suspect, a true increase in incidence of the disease. And another strange thing are some of the subsets of lymphomas. For example, T-zone lymphoma, when it was first identified, was really a disease of golden retrievers. And then we saw it in fairly high frequency in Shih Tzus, but we saw T-zone lymphoma in a Frenchie a few weeks ago and have already seen the second case of that. So what does that tell us? I mean, has this been undiagnosed previously and missed, or is this a disease that is increasing in its incidence and prevalence across the pet population? It's hard to know. And it makes me wonder a little bit, is there something environmentally that's driving some of this stuff, like the T-zone lymphomas? And there's no doubt that cancer is a big problem in veterinary patients. Certainly bigger in dogs than it is in cats, but almost worse in cats than it is in dogs because they hide it until so many patients are so very advanced and the treatment options are so much more limited that it is not an insubstantial problem. It is not a problem that is improving for darn sure. We are increasing our armamentarium, and I think we are diagnosing earlier and helping our patients live longer and live better. But I unfortunately don't think that I can look forward to being put out of a job before the end of my career, which I would love to be the case. I would love to do something different than fight cancer all the time. But I think this really is a problem of this century for our animals. And I hope that by the end of the century, we have made really substantial progress against it.
And hemangiosarcoma, do you feel like you are seeing more incidences of hemangio, just subjectively?
We were until we had a clinical trial looking for cases. I think I'm seeing more horrible hemangiosarcoma that's metastatic in patterns that I did not recognize previously. We see a lot of metastatic to muscle hemangio these days on CT, which I don't know if we just missed it because we weren't CTing as many dogs as we are now, or if it's a change in behavior, but it's gross. And so unfortunately in our practice, we see more end-stage hemangiosarcoma than we do very treatable hemangiosarcoma, and that's been frustrating.
I see. Now, sometimes with immunotherapy, the metastasis pattern changes. And do you see that instead of going to pulmonary metastasis?
Yeah, 100%. We see that all the time, and which makes it quite challenging to know how to recommend restaging these dogs on a routine basis because, that all by itself can greatly increase the expense and invasiveness of needing to do CTs or ultrasounds where we used to just check chest radiographs. But where I used to see dogs with metastatic osteosarcoma that had 12 or 20 circular metastatic lesions in their lungs, I now see dogs die with no metastatic lesions in their lungs. It's in their soft tissues, their organs, their bones elsewhere, or they get one single huge metastatic lesion in the chest with a small number of other smaller ones. I mean, really different patterns than what I recognized at the beginning of my oncology career.
Okay. So if a family had lots of money or insurance, and if they had metastasis, could they try Elias again if they had another accessible tumor?
If I was going to do that, I would want to do it with checkpoint inhibition or some other really substantially active immunotherapy in addition, or combining with radiation, for example.
Okay. Yeah. I recently talked to a family who spent $200,000. It was mostly paid for by a pet insurance company because this dog had three types of cancer in the last 5 years. So
Wow,
he's
poor
luckiest,
thing.
unluckiest dog. Yes.
Yeah, definitely landed in a lucky family. That's good.
Yeah. So pet insurance is important. And
It is.
yeah. Um, Thank you so much, Jeff.
It's lovely to visit with you.
Yes. Thank you. So we'll let you know when this recording is going to be available and post it. And Tammy, Noah, if you're here, thank you so much for the work that you're doing with the team. Okay. Thank you, Jeff.
Take care. You have a great day.
You too. Bye.
Bye.